think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
Hey, Bill.
Yes.
Yeah. Is 4 issues count as one patient, or is there some ratio, right?
Well, there are 2 methods of accounting, you might say, for what you might call the VA's inventory or the VA's work queue, where all these cases are. You can measure, and VA does from time to time, measure the number of veterans served or the number of issues served. And depending on the report you're reading, it may be reporting the number of veterans served, or it may be reporting the number of issues served. And that varies from time to time and place to place, depending on the need for the report. So if you take, for example, the Board of Veterans Appeals puts out an annual report, and you can read that annual report. It's available online just by Googling it. And you can read in there how the board differentiates and says, counting it one way, here's our results, and counting it the other way, here's our results. So it's probably worthwhile if someone has the interest to actually read the report done by the chairman of the Board of Veterans Appeals each year and see what the board does with their cases.
So as far as the rater's work product, he has to do 4 patients a day or 4 cases. There's some variability, right?
That was actually recently revised for most raters. Depending on an individual's level and experience, they may initially be assigned and required to complete cases that will result in 2 points of credit per day. A qualified rater would be required to do 4 1/4 points of credit per day. And they may achieve that by perhaps doing 1 20-issue case or 5 1-point cases, or the way that the formula was set up. Now, that was recently revolved for raters, but not decision review officers. Raters now get a little better credit for the work they do. And decision review officers were, at the time of my retirement a couple months ago, still under the older system. So they were required to do 4.25 points per day.
So how does it work? As a doctor, I find a primary issue, and then there'll be all these secondary issues that I bring in that most people don't talk about. If a rater gets a case and he has all those secondary issues, does he get credit for adding those into the rating, or how do they deal with that?
Yes, it was a proportional system where if an individual filed a claim for, let's say 3 issues. Let's say that a veteran filed a claim for 1 issue, and after it was adjudicated, it turned out to be 3 issues. The rater would then have 1.5 points or credits towards their work for those 3 issues. If it grew to 5 issues, they would get 2 points. if that's clear, I hope.
Yeah. Funny ratios. So I kind of have, if they're in the middle of a case and they find a bunch of secondary issues, it kind of helps them with their points, which makes it more efficient. That makes sense.
Sure. By the way, we were speaking before of the regulations governing PTSD adjudications. You'll find that at 38 CFR 3.304 F. And
Maybe
when
one
you
more time,
look into those paragraphs, okay, 38 CFR 3.304 F. F describes how VA is required to adjudicate PTSD claims for service connection. And only in the part, in F3 is the paragraph, only if you rely on the veteran's fear of hostile military or terrorist activity, only in that section does it say the opinion must come from a VA practitioner or contractor.
Let's go back to that those secondary conditions again for a second. So the rater goes along and he sees these secondary conditions, but if he doesn't have a medical opinion linking them, he has to either overlook them or get a medical opinion on point. All right, Bill?
Generally speaking, it would be an error to overlook them. If an issue is raised by the evidence or expressly claimed by the veteran, depending on the nature of the issue, it may either be incumbent upon the rater to take jurisdiction on that issue and either invite the claim, suggest to the veteran or ask the veteran if they want to claim that specific disability, or in other cases, such as complications of diabetes, it would be incumbent upon the rater to address in the decision all complications of diabetes that are shown in the record based on the medical evidence. It would not be necessary to the veteran to expressly claim those complications.
So sometimes that depends on who the medical examiner is. So, for example, you have a nurse practitioner or a PA, the guy has diabetes, they do an abbreviated exam and don't really talk about the peripheral neuropathy or the retinopathy or the nephropathy, versus a doctor who might go through the detailed examination and talk about those issues. That gives the rater a lot more ammunition to look at to help him make his rating, right?
True, it would. There is, however, some guidance that would prompt that exploration. If VA were to receive a claim with service connection for diabetes, typically an initial evaluation would be performed, and the DBQ for diabetes would prompt the examiner to identify complications that the patient suffers. Then, if need be, those complications would then be referred to a specialist in that area to address and to quantify in order to derive the correct rating for the diabetes and all of its complications.
So the rater would send it out to the specialist from the DBQ?
Yes, the DBQ is specifically designed to solicit a statement from the examiner on the presence of any complications.
No.
Now, on these DBQs, I understand that they're not the same. If you get a CMP examination and they use a DBQ, it's different than they send you. You use the form, I forget, they're all different forms. The form you pull off the internet to give your doctor to fill out. Is that right? They have two sets of DBQs?
There are many more than two. The DBQ is part of an evolution. And the original intent was to try to come up with a standardized examination report so that it would solicit the specific findings necessary to compare with the schedule for rating disabilities. And in this way, provide some consistency in the information being given by the examiners and improve the ability of the rater to use that report, because that report is designed to solicit those specific findings that you find in the rating schedule. And that's been expanding and modifying, and that sort of process has been going on for quite some years now.
So, Bill, like Gerald was saying, I've seen internal DBQs that say, for internal use only, but in those DBQs, they have like a lot of prompts for rationale and a lot of areas where they want the doctor to explain things more than they do on the DBQs that are available on the VA's website. Have you seen that or noticed that, or what do you think? How does that work?
Well, I can only say yes. I've seen different variations on the forms over time. And my understanding is that those modifications were initiated in order to ensure the accuracy of the report and to solicit the best information possible to decide the claim. Now, having said that, recognize this, trying to take the world of medicine and to mold that to fit the world of adjudication is not always going to be a comfortable process.
No.
Like, if you take, for example, that part of the rating schedule dealing with mental health evaluations, when VA promulgated that portion of the rating schedule back in the 1990s, they chose examples of symptoms as examples of the type of symptoms that would justify a higher or lower rating. And they put that list in the rating schedule. That list was never intended to be all-inclusive. Okay, so a veteran may suffer with a symptom that is not on that list. And one of the things that's always struck me as rather startling is the list. If you evaluate a veteran for PTSD, what kind of symptoms are we reviewing? Now, what typically is unique to PTSD is the phenomenon called the flashback or intrusive recollections. There might be nightmares, but that might not be unique to PTSD. But it may nonetheless interfere with sleep and cause debility. Now, if you look at the DBQs, sleep impairment is present on the list. Mood, depression or anxiety, is present on the list. But nowhere on the list is the examiner prompted to report nightmares, flashbacks, or intrusive recollections that are typical for PTSD. And so that's problematic. That's problematic, and there is very little latitude given to the rater to incorporate additional symptoms for the purpose of evaluating the disability that are not listed. And so that might be, if I had an opportunity to invite VA to review a DBQ, I'd probably want them to review that one.
Well, the veteran should be afforded, the DBQ you pull off the VA website should be the same DBQ that a CMP examiner uses. And, that's problematic because you're dealing two different forms here.
I agree, Jack. I agree.
I've seen CP examiners that use those ones that say internal use only. I don't understand why you have internal use only. This is what we're talking about.
I haven't explored that
be
question.
The
I
same
haven't.
form.
Yeah.
Here's a good one, Bill. Back last year, I had an issue with my heart disease on service-connected support, and I filed for an increase. I filed a claim, and of course, I got a response back, did it online, and I fell under a full developed claim because I attached information from an outside doctor with it. And I had a basic diagnosis of atrial fibrillation, some other stuff, and I get a note back from the VA, you need to fill this form out, which is a DBQ. So I open it up, look, here's a DBQ for hypertension. I didn't do it.
I've always found for myself. Attempted to do it. Yeah, here's my DBQ for it's like I mentioned earlier with my own personal claim. I put it in, everything went just great. What I didn't mention was that the letter actually said, here's your temporary 100% for your knee replacement. That's forgivable. With the need for speed, the employees rush, and the more hurry you're in to try to get it done, more mistakes you're going to make. And if there's no harm, there's no foul. They got everything right except in that one place it said knee replacement. So I have absolutely no desire or intent to bring it to their attention.
Well, what I did, I went online and I printed off the heart disease DBQ. I took it back to my doctor and had her fill it out, and I submitted that.
There you go.
And it did knock me out of the full developed claim process, but I got a decision in 6 months. So I didn't worry too much about it. So, but, things like that happen.
Well, we spoke of the fully developed claim. I actually filed mine on what's called the decision-ready claim. Okay?
I remember those.
That's a newer, decision-ready claim, and that works. That works.
Okay, that's good.
What's the difference, Bill? What's the difference between decision-ready and fully developed?
The decision-ready claim compels VA to make the award within 1 month following receipt of the claim. The fully developed claim does not. And it's rather a reward for using a service organization and completing the development for VA up front so they don't have to seek other information. And when you team with the person who knows what VA needs to make the decision and give it to them in a complete package, it speeds their ability, and the promise to get it done in a month gives you the incentive to take that approach to doing business with VA.
What if they deny it? Do you have the right of appeal?
Oh, of course. Absolutely.
Oh, okay.
No question. That would not impact your right to appeal in any way.
I think I'll grab the Legion and find my next one that way. Dr. Bash, I want to give you guys a quick heads up. You guys know effective August 13, 2018, right? Any veteran designated 100% permanent and total and is physically able to do this may fly space available travel. Did you guys hear that?
I haven't. Thanks for sharing it.
Space age travel military?
Yeah, space age travel military. You know, if you retired, you'd be 100% permanent total. But you have to be able to ambulate upstairs and things like that unless you got a special plane. So you might want to check into it. And I don't think you can do it for business. You got to do it like say if you want to fly out to joint-based Pearl Hickam, for a week out on the island, like that, hurricane damage or whatever. That's pretty cool.
Yeah.
So,
That's
not,
good.
and
That's
they,
good. They have your
yeah,
little VA. They have your VA card. What do they need to
Yeah, you gotta
prove
have
that?
you need the TAN ID card. The DAV TAN ID card. Have you got one of them, Dr. Bash?
No, I got a little VA ID card. It's got my picture.
You're 100%, right?
Yeah.
You're 100%, right?
Yeah.
Take your award letter. Go to your nearest issuing base. Any base that issues ID cards under DEERS. Take your award letter, go there and show it to them, and they'll make you an ID card. The same thing as commissary and exchange privilege card. It's NWR card.
Yeah, I guess. Yeah.
I think it's Form 2765, I believe. I don't have it right in front of me, documentation. But, you got a lot of happy vets right now.
Yeah. So how many 100% PNTs are there? Do you know? Any idea?
No, I don't. No idea. I only know that I added to the ranks.
What's that?
Hey, what's the largest retro check you ever wrote, Bill?
Actually, I don't write checks. I just make the decisions.
You know what I mean.
I think I think it was about a little over $750,000.
$750,000.
That was like 6 months after I was employed there.
$750,000. You're lucky you had your job, man.
Should that big one on the outside, right, Bill?
I benefited many years by serving with the Paralyzed Veterans of America, and Dr. Bash and Dr. Bodenbender and other experts were frequently giving us education in medical issues like multiple sclerosis, which affects paralyzed veterans. And so it gave us some insight on what to look for and how to recognize when we might be dealing with a patient with multiple sclerosis. And so this case came to me then when I was a decision review officer, a case came to me about service connection for multiple sclerosis. And from the education I received, I look at the VA examiner's report, and he opined favorably that the MS symptoms started in service. Okay. He didn't specify which service, but when I took the history, service records, and the opinion in context, it was clear to me he was pointing to a certain presentation of symptoms near the time of the veteran's discharge from active duty, even though he didn't expressly state that. And so I granted it. And that large of a check requires additional reviews from higher management. And they kicked it back and said, well, the examiner didn't specify which period of service. So they felt it was important to go back and ask the examiner, which I obeyed. And the examiner came back and said, all of them. Okay, I granted it again, and by the time it got through that loop, another $100,000 retro. So, no, but see, it's important I've got to share with you the fact that there have been instances of fraud. People on the inside and people on the outside of VA in collaboration have at times conspired and defrauded the government of payments. I've witnessed it. I've read of it. And so for that reason, it's reasonable for VA to have some checks and balances to review some cases, particularly ones with large retroactive awards, and just for common sense review to check for their authenticity. I have no problem with that. But I just was fortunate, and fortunately for that veteran, I was able to find and understand what the doctor intended and grant on that basis, where some people without that experience might not have been able to.
Well, Bill, you bring up the point of this intellectual teamwork, you know? Like, we would teach you about the medical part, you teach us about the legal part, you know, and that intellectual teamwork is really valuable because this is really a melding, like you said, of the legal with the medical, and it's difficult.
Yes. And sometimes with something as complex as multiple sclerosis, the patient is often not the best source. They wouldn't know what to look for.
A lot of them have mental illness. They can't use their memories or their logic and have a hard time weaving their way through the cases.
Yeah. Yeah, I've often felt a great deal of sympathy for people with severe emotional distress and trying to deal with rather complex issues of medicine and law. It takes a helping hand.
Yes, it does. It really does.
Thank you all for listening. That ends this show. And now I'm going to zoom off.